Happy Thursday, everybody. Thank you all for joining us. Today is an all internal CP Solvers affair, but we'll start, of course, with handing the mic to the people who are making this happen and scribing for us today is Selsan. And Selsan, I'll hand the mic to you to say hello and update us on what's new.
Hi everyone. I'm Sosan. I'm so happy to be here and to do scribing for Animal's case. And what's new is I started my emergency medicine rotation this
Oh,
week. So it's kind of
oh,
exciting.
how's that been?
Nice, actually.
Uh, do you like the acuity, or where do you find yourself gravitating to the stable patients or the very sick patients, or what's your instinct?
Oh no, I'm more to the stable
So
patient.
you know, I'm listening.
Amazing. That's awesome. As you stretch your comfort zone, I think you'll find yourself gravitating in. We'll see. Lyra, what's new with you? Thank you for doing teaching points today.
Hi everyone, my name is Lera. I'm a medical student from Russia. What's new is I think I have an unexpected day off today, so I'm really happy about that and so excited about Patricia's discussion and Almo's case.
How did you get your day off? What happened?
I don't know, it's just it came up.
When did you find out? Like after your day started or before?
Actually, after my day started.
Oh,
Yeah, it
wow.
was really
Even better.
unexpected.
Oh my gosh. Wow. Well, that's the inverse of our case discussant today, Patricia, who is still just finished work. Before I hand the mic to her, as we always do, these first-time discussions with, which it is the case today for Patricia, as a celebration of tremendous work. So Patricia has now been part of the team for a little bit less than a year. We got to know each other a little bit later last year when the weather was warmer. Um, after she had spent basically a month on VMR and nowhere else seemingly. And since then, we've gotten the chance to invite her into the team and see just how much she is shining in so many different places. Very, very consistent feature in our space. And the last time I think I got the chance to talk with you directly on VMR was after your incredible case that you presented to Reza and I. So very, very excited to welcome you back and to co-discuss with you. I'll hand you the mic to say hello, and then we can introduce our case presenter.
Hello, everyone. Thank you, Dr. Rabih, for the kind words. You are so good. So I'm really excited to discuss with you. Like, it's a pleasure. I don't know what had Anmol has prepared for us, but I hope I will be able to keep up. So yeah, really excited to learn. Yes.
Yeah, I think very, very well said. Whenever Anmol presents a case, we're in for a wonderful journey and we'll learn a lot, I am sure. Anmol, I'll hand the mic to you, maybe just to update people on how you're doing, where life has taken you, and then after we can jump right into your case.
Hello everyone. So excited to be back at the case presenter seat. It's been a long 2 to 3 months now, but I'm very excited for today's discussion. I just came back from my night duty yesterday, and I'll be going to my night duty today after the case. And we all will learn a lot from this case today. So I'm really looking forward to the presentation.
Me too, Anmol. Let's do it.
Okay, so I have divided this case into around 7 to 8 aliquots. So if we start with the first chief complaint, that is a 68-year-old male who came to the emergency department with the complaints of shortness of breath and dizziness for 1 day. I'll stop here.
Oh, Anmol, very, very helpful. Patricia, yeah, how are you thinking about this information so far?
Okay, for like 68-year woman, we came with shortness of breath. I know in the CP solver we have a schema for shortness of breath where we usually start the bottom is I think it's the heart, like different causes are from either from the lungs, the heart, and other causes like maybe anemia. And yes, that's what I have in mind for now. And the process is pretty acute. Just so in my mind, I have like the schema for shortness of breath, and then I see the dizziness and the time course is also acute. So I'm thinking about maybe an acute process. So that puts maybe anemia downside my list if I have to class it. But I think I will need more information. For now, I just have like the general schema for shortness of breath. Like I'm thinking about heart, lungs, or something, maybe anemia or something like that. Yes,
Yeah.
that's what I have for now.
Excellent. Yeah, I think you definitely need a lot more information, but you're steering in the right direction, and at the end of the day, um, I think medical training teaches us to try to have the answer as quickly as possible. But the truth is, when you're just starting to get to know a
Did
patient,
you lost me?
oh, can you hear me or? Oh, I think her video is frozen. Oh, all right, we'll see. But yeah, I think all your initial job is to make sure that you're driving in the right direction and not the wrong direction. And I think Patricia laid it out very well. The shortness of breath approach is really to emphasize the heart, the lungs, and then the blood. And I think if you ask yourself how the dizziness helps you filter through that and make progress through that, I think you'd realize that dizziness fundamentally is either a vertigo problem or a vascular problem. And so the combination of shortness of breath and dizziness fundamentally emphasizes the cardiovascular system as the cause that lives in both worlds. It's relatively uncommon for pulmonary causes of shortness of breath to cause dizziness, though of course you may come up with many ways to do that, including say somebody has pneumonia, hasn't been eating or drinking well, and therefore is dehydrated. But I would say that whenever I hear these two things, I imagine that there's something wrong with the cardiovascular system, be it devoid of hemoglobin, or that there's an obstruction like a pulmonary embolism, or that the patient has suffered a loss of contractility. So I think the plumbing is the problem likely here. And so, yeah, we'll see what other information Anmol gives us. But yeah, shortness of breath filtered through dizziness really emphasizes the heart and the blood. All right, Anmol, what do you have next?
Wonderful start. I intentionally stopped at the chief complaints because that is the only thing we mostly have when the patient comes to the ED. So we just need to stabilize the patient. So HPI is that the patient has baseline shortness of breath on exertion, that is of NYHA grade 3. But this time the dyspnea got exacerbated for one day, which was present at rest as well. And it was accompanied by an uneasy feeling and some chills as well. He also reported having cough with expectoration, and there was no history of any recent fever. Regarding the past medical history, the patient is a known case of type 2 diabetes mellitus, and for it, he is taking some sort of oral antihypoglycemic agent. Family history is not significant, and there are no known allergies. Regarding the social history, there is no history of any recent travel. The patient does not drink alcohol and does not smoke, and there is no known animal exposure. Regarding the physical examination, at the time of presentation, the blood pressure of the patient was 100/60, heart rate was 112, respiratory rate was 24, and the patient was saturating at around 94% via nasal bronchs. And temperature was afebrile at the time of presentation. He was conscious and oriented to time, place, and person. Pallor was present. Pupils were normal, bilaterally equal in size and reacting. There was jugular venous distension. No evidence of icterus with normal conjunctiva. Soft, hard sounds were heard, and the JVP was raised, as I mentioned. Rest all of the system was unremarkable. That was within normal limits. I'll pause here.
For those of you who are listening to this live or later on YouTube and you're realizing just how skilled Anmol is, Anmol, you're like an outstanding case presenter. And I think it's been amazing to see your growth at CP Solvers. And I just wanted to take a moment because I'm noticing just how amazing a job you're doing is to tell everybody else that you could have the privilege of Anmol mentoring you and coaching you about how to present just like her. She is part of she is not part, she is one of the 4 leaders of the case review committee. And so I just take a little break, like 10 seconds, to show you that if you have a case and you need some advice about how to present it to us, hit up Unmol. And the way you find Unmol is not through our personal context, that would be very rude, but through here. You just go to our main website and you click morning report and present a case, and you will very likely bump into Unmol. Okay. Anyway, a brief diversion. Sorry, Unmol, your skills are too good. Patricia, what has happened in your mind with this information? I think you're muted, so only you can hear you, my friend.
Sorry. So we have more story about the shortness of breath, and it looks like it's something that happened acutely on something that is already chronic.
Mm-hmm.
So first I would thought about maybe an infection, but I see that the temperature is normal.
Yeah.
What else do I have? There is no fever, but there is a cough.
Yeah.
I don't necessarily discard an infectious process because of the lack of high temperature. So I would still put it like on my differential, like maybe an infection. And yeah, now my thought is mostly like something acute on something chronic, like something that exacerbates the shortness of breath. And I can just think about an infection. What do you
Yeah.
think?
I'm going to give you a piece of advice in real time. I think what you're doing is you're trying to find the category of disease. And I think that's one really important thing that we have to do. What is this disease? Is it infectious, vascular, malignant, autoimmune? But I think in parallel, we have to find out where the disease is. So what is it? Could it be an infection? And next to it is where is it? Is it lungs, heart, blood? So you're starting to think, chills, tachycardic, maybe infection. What are your thoughts about where it might be? Heart, lungs, where do you think the problem is?
About the where, I'm still on the cardiovascular system, like either the lungs or maybe the heart. Yes, I'm not sure that it's something like generalized into the blood or maybe the brain. I'm still on the cardiovascular system.
Yeah, me too. Me too. I think what happened was, I think the acuity of the illness probably diminished when we learned that Unmol discovered that this patient has baseline shortness of breath on exertion. And so the fact that he feels more short of breath is not from zero to complete lack of breathing, but rather from a already vulnerable baseline. But the problem is that when we look down and we try to see, has his baseline shortness of breath been explained? We don't have an accompanying diagnosis that explains why he would be short of breath at baseline. So that makes our job very, very hard, because now we have to explain why he's acutely short of breath, but also why he's been chronically short of breath. And so if I were taking care of a patient like this, I would be very on guard, because I think that what we could be dealing with is a progressive process that has been inflicting suffering on this person for a long time and just happened to get worse. Or we might be dealing with two separate diagnoses, the chronic one and the acute one. So the complexity in this case is very high. And whenever you have complexity, really, you just have to be able to try to get as much as you can from your eyes. So when we look at this patient, Patricia, I think we should worry quite a bit because he's tachypnic, tachycardic, and hypoxemic. He's pale and he has a distended JVD. The illness severity of this patient is very, very high. And so I think the biggest marker of severity is the tachycardia here, because the hypoxemia and elevated JVP paint a picture of somebody who is in decompensated heart failure. And when you're in decompensated heart failure, the most likely form of a tachyarrhythmia, the most likely cause of a tachycardia is a tachyarrhythmia. So hopefully, this patient has a supraventricular tachyarrhythmia like atrial fibrillation, which would not raise significant concern about impending cardiovascular collapse. I'm sure we all know that if this EKG showed ventricular tachycardia, we would all be very worried about this patient. But I will tell you, you should be equally worried about ventricular tachycardia as you should be sinus tachycardia. The presence of sinus tachycardia in a patient with evidence of heart failure is a very ominous sign that predicts either a serious underlying cause or progression to cardiogenic shock independent of the underlying cause. So initially, when you heard the chief concern, Patricia, you were like, okay, I'm worried. Like only one day, that's acute. And then with the HPI, we become less worried because he's had this for a long time. But then you look at the exam, and I think you should now almost panic. Um, so Sausan was seeing the less acute patients in the emergency room, but today this patient is not on the less acute side. I'm very, very worried. And so I think we should be very, very cautious about what's about to happen. Let's leave it at that because Anmol has a total of 7 aliquots, so I'm sure we'll get more information. But I'm right there with you. I think it's the cardiovascular system. I'm concerned about how serious it is. I don't have any thoughts about what the cause is yet because I'm still so focused on figuring out where the problem is. So Anmol, give us your next aliquot if you don't mind.
Wonderful discussion. We'll talk about the labs now. The hemoglobin was 90.2 with an MCV of 98.8. TLC was 20,500 with neutrophils predominant, neutrophils being predominant. Platelets were 4,72,000. And regarding the electrolytes, sodium was 135 normal, potassium was 4.6, and chloride was 102. Then calcium was 8.1, phosphorus 4.7, and magnesium was 2.0. ESR was raised at 88, BUN was 40, creatinine was 0.9, and LDH was 299. Total serum bilirubin was 0.6, AST was 39, ALT 67, serum total protein was 6, albumin being 3, alkaline phosphatase was 142, and serum total cholesterol was 90. Then their other values were also done. CKMB was 2.8, myoglobin was 403, TROP-I was 0.05, BNP was 77, and D-dimer was 2,130. The viral markers were also done, and the patient was found to be non-reactive. I can briefly pause here, and then I can show the ECG.
Yeah, perfect, Anmol. A great decision to pause here. Patricia, you are a very smart. You said infection, infection, infection. And I honestly, I don't know if I was feeling infection, but I think you were right. So let me hand the mic to you to hear more about what you're thinking about these labs.
Okay, so now definitely we have infection. The white blood cell count is really high, neutral predominant. So maybe we can think about it might be a bacterial infection. And there is an anemia, like a moderate anemia, and it looks like it's from chronic disease, like it's not from the iron. And the platelet counts are a little higher. So from the CBC, I'm thinking about maybe bacterial infection. So I'm thinking more about an acute process on a chronic process. Maybe the patient has, as you mentioned, the patient has like shortness of breath for a while. We don't know why, but the infection came and decompensate. The decompensate is baseline. Yes, I will put it like that. Yes. What do you think, Ravi?
I'm right there with you. I think that, this patient appears to be acutely inflamed and therefore likely infected. And we have the localizing symptoms here. So now, Patricia, you and I have to have a discussion in general, not in this case. So in general, what are the most common forms of infection that live in the chest? What do you think?
In general, we have infection of the heart, like endocarditis, myocarditis, pericarditis,
Excellent.
and of infection of the lungs.
Yep.
It can be from the parenchyma,
Beautiful.
like pneumonia, parenchymal pneumonia. It can be interstitial, like interstitial pneumonia. It can
Beautiful.
be we have the parenchyma, we have even I think the lining of the lungs.
Yeah.
I can
The
be
pleura,
inflamed.
for sure.
Yes. So that's what is coming for me
Yeah.
right now.
Well, a lot has come for you. That was excellent. Now, let me ask you one quick follow-up question. What is the most common of all those things,
um,
most common that you've seen?
I would say an infection from the lungs. They
Exactly.
are most common.
And what's the least common?
Yeah, pneumonia. The least common, myocarditis.
Yeah. So let me share with you what you just did. The closer you are to the world, outside world, the more likely you are to get an infection. The deeper and deeper and deeper and more sterile you get, the less likely it is that you have an infection. Why? I mean, it's very easy for a bug to make it into the lungs. It's much harder for a bug to make it into the myocardium. So on the one hand, if you say the patient has a neutrophilic leukocytosis and has respiratory symptoms, you would really prioritize pneumonia. However, when patients with pneumonia have this degree of a leukocytosis, they're often much more hypoxemic and much sicker. And so a disproportionate neutrophilic leukocytosis is one clue that should make you say, maybe I'm dealing with something less common. And the deeper you get, the less and less common it gets. So empyema would be second most common. Then endocarditis would be third most common. Mediastinitis, myocarditis, and pericardial disease. And this is why I think, Patricia, it was very helpful to keep our two thoughts separate. Where is this? And what is this? And I think the what has become very, very, at least the focus of the what should be infection, infection, infection. The focus on the where, you've been saying cardiovascular, cardiovascular, cardiovascular. And I think that that's really important to entertain. So now you're saying, okay, maybe we should think about a cardiovascularitis, endocarditis, myocarditis, pericarditis. What do you think about the BNP? How is the BNP fitting here with you? What are you doing with the fact that this person's BNP is normal?
Oh, I missed that. The BMP is normal means that the heart is not so much strained because when we had the at the physical exam with the GVG, we could have thought that maybe the heart is weak, like is in a weak state. But
Right.
with the BMP being normal, our focus needs to shift.
Yes.
I don't know. It's either way, there's something wrong with the lab, or our focus needs to do something else. I'm also looking at the data. I'm like,
Yeah.
okay. I think it comforts us that the problem might coming from the lungs. I don't
Yeah.
know.
Yeah, you have to
Yes.
start
What
to
do you
say,
think?
maybe I was wrong. Maybe it's the lungs all along. It's much more common. And that's definitely true. By the way, you sound like a very seasoned discussant by we have to shift our focus. That's like almost a professional level. I can't believe this is the first time you're doing it. But so you have to say your reasoning is outstanding. Was I wrong? Is it the lungs? Is the lab wrong and the BNP is an error? Or is their BNP telling me something? And I think what you have to emphasize with the BNP is the pathophysiology. So the BNP is a consequence of left or right atrial stretch. And the answer to having a high heart failure, JVP, with a low BNP is that your atria are collapsed and your atria are completely occluded, and that's why your JVP is high. And so in this context of the things that you mentioned, endocarditis, myocarditis, pericarditis, pericardial disease would be the most elegant explanation for why somebody has heart failure with a low BNP. And the BNP is low because the atria are not stretched. In fact, they're completely collapsed and blocked. And that's why blood cannot empty from the internal jugular vein into the right atrium. The realistic answer in most people is that two more common conditions account for heart failure with a low BNP. The first being patients with a high BMI. That's because BNP is cleared by adipocytes, and the more adipocytes you have, the more BNP is cleared and lower it is. It's actually fairly common. About 1/3 of patients with heart failure with preserved ejection fraction have a low BNP. But none of those patients have an acute hectic inflammatory presentation. So I will tell you what I would be thinking in real life. In real life, you're grounded in frequency of disease. The last patient's illness informs how you think about this one. And so you have to think neutrophilia plus thoracic symptoms, pneumonia, pneumonia, pneumonia / empyema. That's what's going to be the most likely outcome. But based on the JVP elevation and the chronic history of possibly heart failure, you have to entertain the heart. And the most important hypothesis right now is pericardial disease. Why? It's one of the most morbid, rapidly progressive spaces if you have an infection. And I would be very worried if that's the case. So what should we look at the EKG for? We should look to see, is there tachyarrhythmia or not, as we discussed earlier? And is there evidence of pericardial disease on this EKG? So even before you look at the EKG, you have to have the pretest probability. So as soon as Anmol shares it, Patricia, let's see if we have any evidence of arrhythmia or any evidence of pericardial disease. Okay, Anmol, the mic is yours, my friend.
Wonderful, wonderful discussion. Now I will share the ECG for you all to interpret it.
Oh my gosh, it's so small I can't see it. I'm just kidding. Just kidding. That's a little hint for you, Patricia. What do you see?
Okay. I've been trying to learn how to read EKG, so let me see if it has been working. I know we need to start with a systematic way to see if we have a sinusal rhythm. I can see a P wave be formed every QRS, so I would say it's sinusal rhythm. And from what I see, it seems irregular. I would say so. It's a regular sinus rhythm, and it looks fast. So I'll say that maybe there is a tachycardia. Yes, it looks like 100 or little less than 100. Okay, so looking at the P wave, the P wave looks like little small. It's not like your usual round shape. It's a little, shortened. And same like for the QRS amplitude. The time course looks normal, but the amplitude is small, and the amplitude of QRS looks more like on every lead. And I know diffuse micro voltage of QRS usually is a sign of pericarditis. Yes,
Yeah.
that's all I have for now.
Outstanding.
Okay.
I'm gonna go home now and just relax and sleep. You don't need me. So I'll just share with you two things. And then I would love for all of you to go into just a 3 to 4 minute breakout room to discuss what you would do next, because this is a very, very important case. Very, very important. Fact number 1, this is sinus tachycardia, borderline tachycardia. The combination of sinus tachycardia and heart failure means one of 3 things: impending cardiogenic shock, regardless of etiology, or high output cardiac failure, or obstructive cardiogenic shock. So when you see that this patient, you have to think, are they going to have cardiogenic shock now? Do they have high output cardiac failure? The answer to that is no. We'll talk about that another time. Or do they have an obstructive form of shock, i.e., pulmonary embolism, hypertrophic obstructive cardiomyopathy with outflow tract obstruction, or pericardial effusion? And so when you look at this voltage, you say, okay, why is the patient's heart not meeting my EKG lead? And it could be because the patient has a high adiposity, a nice hypothesis with his BNP. Could be because he has COPD. Could be because he has pericardial effusion. Or it could be because he has no heart muscle. If he has no heart muscle and he has heart failure, you should have a high BNP. So the combination of low voltages and a low BNP either means adiposity or pericardial effusion. And so if you just look at this patient and you can infer the BMI, you'll be able to make progress on which one it is. So Anmol, do you remember roughly what the patient's BMI might have been?
It was normal. It was
Normal.
yes, it was normal.
That's really important, right? So I'm gonna love to open breakout rooms for you all for just 3 or 4 minutes. And Patricia, feel free to go and learn and share your thoughts with the breakout room if you like, or you can just collect your own thoughts. But I would recommend you go because you are paired with some very smart people. We'll see you all back in 3 to 4 minutes, okay? All righty, welcome back, everyone. I hope you had a fun conversation. To summarize, we have a middle-aged man with a history of diabetes who is presenting with acute on chronic shortness of breath and found to have neutrophilia, thrombocytosis, low voltage EKG with tachycardia, and with a concern for pericardial disease. So, Patricia, anything that you chatted with your team that you wanted to share out loud before we get more information from Anmol?
I love the thought process in our chat group. I was with Menu and Hans, and we talked about what do we need to do next. We were all pretty adamant that we need an echocardiogram to see more what is going on in the heart.
Yeah.
And our thought were going more toward cardiac tamponade.
Yeah.
Cardiac tamponade will explain, and if we based to the explanation also that you gave about the low BNP, which means that the atrium might be collapsed. Like I think our chat group was was just how do I put it? What was just like giving more weight on that thought. Yes, cardiac component.
Amazing.
Yeah.
I'll share 2 pieces of advice. I think the momentum towards an echo is huge. And I think if you ask yourself, where does pericardial disease come from? Where does it originate? I think the possibility that there is a pericardial disease that has extended from adjacent disease in the lungs or the pleura means that in parallel, I would also be recommending a CT chest with contrast, which will allow us to really understand the extent of the disease. I think the mistake that can happen here is that you get your blinders on and you really like pericardium, pericardium, pericardium. But both the base rate of thoracic inflammation, which suggests lung and pleura, and the fact that the lung and pleura can erode into the pericardium and getting that bigger picture view is really important. But you also have to zoom in on the pericardium because of what you mentioned. And I think there's 2 pericardial emergencies. One is pressure, pericardial hypertension causing tamponade, but the other pericardial emergency is pus. So remember the 2 P's, pressure and pus. And the idea that there might be pus in the pericardium is a major, major issue. So I would be pursuing these tests, CT chest with contrast and transthoracic echocardiography with tremendous velocity. So Anmol, what did you all do?
I have another screen to share for that. I have a chest X-ray before we go to the Um, can you see it? I can't hear. I can hear you, Dr. Rabih.
Oh gosh, sorry. I didn't realize I was muted. Oh, um, yeah, Patricia, what do you see? And now you're muted too. Wow, we're gonna just keep staying muted, both me and you.
Yeah, this chest also is definitely not normal. The heart look like huge, like really big, and on the left side, we are not able to see the lungs. I it looks like there is an infection too, like infection, like a lobar infection, because I'm not able to see like the uh I don't know the diaphragmatic like couple. I don't know how we put it in English. But
Yeah, no,
yes,
no, yeah,
so I'm like maybe
yeah,
there's something in the lungs,
beautiful.
definitely, and there's something in the heart too, or it just might be the pericardium,
Mhm.
which is full of fluid that does not allow us to see other structure around. Yes,
Outstanding.
so
Yeah, outstanding. I think you'll notice that the cardiomegaly here is very unique. It is a bottle-shaped cardiomegaly. The heart is not elaborated and extended to the left. It's elaborated and extended to the right. The differential diagnosis of that is the patient has right-sided hypertrophy or RVH, or that there's pericardial effusion. And so the nature of the cardiomegaly here is very telling. I, like you, cannot see the left costophrenic angle. And so I worry that it's either absent from a pleural effusion or a pulmonary process, but it might be occluded because of the heart. So I think the pericardial hypothesis now has features on history, on exam, on labs, and on imaging. So it's very, very concerning. And so the question is there pericardium under pressure, or is there pus in the pericardium? Are the two most important things.
Yes, right on point. And I will share my the report of 2D echo along with it. It revealed large pericardial effusion, 2.6 centimeter interiorly and 1.4 centimeter posteriorly, right ventricular diastolic collapse, concentric LVH, grade 1 diastolic dysfunction, mild to moderate TR, the features of whole which were suggestive of cardiac tamponade. And in fact, the patient was referred to us from an outside hospital with with the echo findings of these. So we knew initially that the patient is having cardiac tamponade. So what would you do next?
Yeah, Patricia, what do you want to do next? I think you're you're muted still.
I I'm not sure. I really don't know.
Yeah, no, I think we can
What do I
talk it
want to
through.
do next?
Yeah, now that you have a high pericardial tamponade means that the pressure in the pericardium is so high that it's collapsing the right ventricle.
Mhm.
And so what do you think you can do to relieve that pressure?
Okay, so I've been seeing that in the chat, pericardiocentesis. Like, is it a needle that we send to the pericardium? I guess it's a procedure. So I will do that procedure to relieve the pressure on the heart.
Yeah. Yeah. Do you know how to do it? Okay, don't worry. I can teach you over Zoom. It's very easy. I'm just kidding. No, I don't know how to do it either. So the question then is, can you do anything for this pericardial tamponade? What do you think?
Maybe give like some medicine, I think Lazilix, like furosemide.
Okay, now
Does it?
I want you to remember this conversation forever. Okay, you ready? And then one day, maybe 5 years from now, you'll call me and you'll say, thank you to Anmol for teaching me this lesson. You do not want to give this person Lasix. You want to give the opposite. Let me explain, okay? So, if you picture this to be the right atrium, okay? This whole cavity right here. And now it's being squished by pericardial hypertension. You ideally would just resolve the pericardial hypertension by removing the pericardial fluid and then, okay? That's the best ideal. But that takes time. You need at least 30 minutes to do it. So what can you do if it's like this is you put fluid inside it. So this form of heart failure requires fluid administration to push back against the pericardial pressure and to open the atrium. This conversation gets complicated because if you give too much fluid, that can cause some other problems. But in the presence of tamponade, the only real temporizing measure available to you is IV fluid administration to increase the intra-atrial pressure inside the atrium, which can push back against the pericardial pressure. So in this patient, IV fluids, pericardiocentesis, and very importantly, the differential diagnosis of tamponade with neutrophilia has to include the most morbid, one of the most morbid causes of pericarditis, which is purulent pericarditis. So in this patient, broad spectrum antibiotics are very, very important because our hypothesis is that this is a pericardial infection. And so when we do the pericardiocentesis, we have to look to see, is it pus, and send it for culture. And the overwhelming evidence so far suggests that this will be pus. So I would give this patient IV fluids. I would give this patient vancomycin and ceftriaxone. And then I would ask somebody who knows how to do it to do a pericardiocentesis. I don't know, what did you guys do?
Wonderful discussion. This is a great point that whenever a patient comes with shortness of breath, we sometimes can assume that patient is having ADHF and then we give Lasix. But Lasix can actually cause hypovolemia, which can exacerbate the hypotension and lead to hemodynamic instability in the cases of cardiac tamponade. So we avoid nitrates and Lasix. That was a great point. And definitely then we did a pericardial tap. And the pericardial tap was done. The fluid was found to be hemorrhagic. Amount of fluid removed was 450 ml. Cytology for that was RBC count was 7 lakh cells per millimeter cube. TLC was 6,600 and neutrophil percentage was 30%. Then regarding the fluid biochemistry, albumin was 1.99, glucose was 62, protein was 4, pH was 7.5. ADA was 410, amylase was 52, and LDH was 2,672. Lipase was 16, and the CB0 test was performed. Mycobacterium tuberculosis was not detected. Gram stain showed that no microorganisms were seen. ZN stain revealed that no AFB were seen, and fungal smear, no fungal elements were seen. I'll stop here.
So Anmol, just for clarity, how many more aliquots do you have? I want to make sure we don't talk too much.
One more aliquot because we need to find the cause of the pericarditis.
Perfect. So you have one more aliquot, and then after that, the diagnosis. Okay, perfect. So Patricia, what do you think of this pericardial fluid result? What are your thoughts?
This is so great. First of all, Amol, your case is really interesting. When I saw hemorrhagic fluid, my mind first went to TB, and then she told me that the TB was negative.
Yeah.
Okay, so if the TB is negative, I don't know, like maybe some malignancy. I know malignancy will increase your um,
Yeah.
your inflammatory marker,
Yeah.
and it would cause that type of pericardial effusion. It's just, yeah, I'm I'm leaning toward malignancy. I don't know. What do you think, Ravi? How
Yeah,
do you
excellent.
read, like, especially what do you make of the lab from the pericardial tank?
Excellent. I think if you're asking yourself, what is the differential diagnosis for a pericardial effusion? I think in all comers, the most common cause is a pericardial effusion that is idiopathic and we don't know why it happened. That accounts for up to 70% of patients with pericardial effusion. However, that diagnosis is not at play when two things are present. Either there's tamponade. Tamponade from idiopathic pericardial effusion is pretty rare. And when the pericardial effusion is accompanied by signs of systemic inflammation. So even though idiopathic pericardial disease is the most common, it's fairly unusual to progress to tamponade and certainly very unusual to cause a neutrophilic leukocytosis. So then we bypass that and think about the three most common causes of a pericardial effusion that are not idiopathic. Cancer, and cancer is the most common cause in low TB endemic regions. Then infections. The infections come in two flavors, pyogenic infections like staph or strep, but also tuberculosis. And then finally, what's called injury-related pericardial disease, where you can have pericardial disease after an MI, after cardiac surgery, after ablation, and adjacent thoracic injury like pleural disease or pulmonary disease. So what happens is the pericardium gets irritated when there's injury around it, be it myocardial injury, pleural injury, or pulmonary injury. The focus on patients with tamponade is always infection or cancer. And I think the concern for infection or cancer is certainly heightened by how high the LDH is. So we really have to ask ourselves, is this cancer or is this infection? But the probability of this being purulent pericarditis, i.e. a pyogenic bacterial infection, is low for two reasons. Three reasons, I would say. The first is the Gram stain is negative, which is good, but not perfect. The second is that the patient does not have a neutrophilic leukocytosis. And the third is the size of the effusion. When you have 450 cc's in your pericardium, you know it's been there for some time. Because if a small amount of fluid makes it into the pericardium, and the pericardium is not used to it, the patient gets tamponade very quickly. Even 70 cc's of fluid, i.e. from blood, can make an unadapted pericardium go into tamponade. So the fact that this pericardium has 450 cc's in it means that this process is subacute, i.e. the patient's baseline is now relevant. So a subacute inflammatory pericardial effusion is either malignant or tuberculosis. And the problem with tuberculosis is that the sensitivity of analyzing the fluid is very, very low. The way to rule out tubercular pericardial disease is to do a pericardial biopsy or to find tuberculosis somewhere else, like in the lungs. So, Patricia, I think we now know that it's important to frame this case as that the pericardium is part of something systemic. Either there's a systemic cancer that has eroded into the pericardium, or there's a systemic infection like TB. So I think the most effective way to make progress is to remove our fixation on the pericardium and look to see if the lungs, the skin, or the abdomen has a clue as to what is involving the pericardium systemically. If we are unable to find a systemic fingerprint to this disease and update our problem representation to an isolated pericardial one, the only way we'll make progress is through better imaging, like an MRI or a PET-CT, but more realistically, through a pericardial biopsy. I think in all comers, the fact that this patient does not have cachexia, weight loss, or other markers of systemic malignancy would have me favoring tuberculosis in this patient, which can disproportionately affect the pericardium. But let's hear what Anmol has to say, and then we'll reflect on the final aliquot together.
Yes, wonderful discussion. And the next investigation we will do is the one Dr. Rabih was asking 2 aliquots back, that is chest CT with contrast. So a CCT chest was done, and it revealed multiple well-defined round-shaped macronodules of various sizes noted in bilateral lung parenchyma. Multiple centrilobular nodules in tree and bud pattern were noted in bilateral lung fields, predominantly in middle and lower lung zones. Patchy area of consolidation and ground glass opacities were noted in central and peribronchovascular distribution in left upper and lower lobes. And then there was partial collapse, consolidation of left lower lobe of the lung, and left-sided mild to moderate pleural effusion was also seen. Along with that, there was a large, heterogeneously enhancing soft tissue density in anterior mediastinum with irregular and lobulated margins, measuring about 12 by 20 into 7.8 in craniocaudal transverse and AP dimensions. That was noted predominantly epicentered in prevascular space with extension into middle mediastinum. This lesion was inferiorly extending at the level of aortic root and infiltrating pericardial space with associated gross pericardial effusion. Posteriorly, this lesion was encasing ascending aorta, aortic arch and its branches, and main pulmonary artery with loss of fat plane between them. And this lesion was also causing compression of SVC and left atrium. Superiorly, the lesion was extending at the level of left first rib, and it involved mediastinal surface of pleura over left side. And there were multiple enlarged mediastinal lymph nodes of size up to 13 mm noted. So in summary, we had a heterogeneously enhancing anterior mediastinal mass, suspicious mediastinal right hilar bilateral internal memory nodes, suspicious pulmonary nodules, and mild bilateral pleural effusion along with gross pericardial effusion.
Anmol, this is absolutely amazing. And I think it just really illustrates the point that you have to be very careful when you have an emergency in front of you, a tamponade, to not just get fixated on that. And to realize that most of the time when you have an emergency somewhere else, and most of the time when you have an emergency somewhere, that the rest of the body is not happy. There's often something else going on somewhere else. And after you tend to the emergency, here draining the fluid, you have to broaden your gaze. And so, Patricia, how do you think about a mediastinal mass? What thoughts are crossing your mind now?
Mediastinal mass, that's a knowledge gap for me. I'm sorry, it's been a while. I know there is something, mediastinal mass, it could be from the thyroid, from
Yes.
the tubular.
Yeah, correct.
I'm not sure. I'm not
Yeah.
sure.
You're using, maybe you've heard or subconsciously you're using the mnemonic of the T's because you just mentioned 2 of them. The most, I'll just say for simplicity, the most important T's to keep always in your mind for anterior mediastinal mass is a thymoma and what's called terrible lymphoma. You remember now?
Yeah, yes.
Yeah. So I think, if we just go back, Patricia, to our conversation earlier, we were thinking, okay, cancer or TB. And I think when you have an anterior mediastinal mass, you really have to worry about cancer. And thymoma does not invade adjacent structures. So you really have to worry, could this person have a terrible lymphoma? The reason to not commit definitively to a malignancy is that aggressive forms of fibrosing mediastinitis from tuberculosis can also present in this manner. So I think it would be a mistake to say, oh, anterior mediastinal mass, this is lymphoma. I think that it's very, very plausible that an anterior mediastinal mass, especially with the pulmonary nodules, could be an aggressive form of fibrosing mediastinitis from tuberculosis. I think the simplest thing to say now, Patricia, is to say you found a much safer place to biopsy. Instead of biopsying the pericardium, I think now you can analyze the sputum for AFB to see, do you find tuberculosis in the sputum? And you can do a bronchoscopy with biopsy of the lungs, the affected lungs, and potentially either bronchoscopically or percutaneously biopsy the anterior mediastinal mass. I will say that if you are trying to use the CBC to help you, neutrophilia is very much in keeping with tuberculosis, but also in keeping with one specific kind of lymphoma, namely Hodgkin's lymphoma. So I would be most worried for this patient's overall prognosis about Hodgkin's lymphoma, but I would not be surprised if this patient has tuberculosis with fibrosing mediastinitis. I said a lot, and I'm saying it in a short time because we're out of time. But I'd love to see what part of this is still confusing or unclear to you, Patricia, before we hear the diagnosis from Anmol.
No. For now, I'm able to keep up. I don't have anything.
Yeah.
And that is not unclear. So I will just wait on Amol to continue.
Sounds good. All right, Anmol, mic to you, my friend.
Okay, so the next step, ultimately the diagnosis was made by a test that is CT guided biopsy for the mediastinal mass. And it revealed that there were fragments of a thymic epithelial neoplasm in vague lobular architecture delineated by fibrous septa. Lesion was composed of spindle cells, type A component, admixed with aggregate of small lymphoid cells containing clusters of polygonal epithelial cells that was type B component. On immunohistochemistry, epithelial cells were diffusely positive for P63, focally positive for AE1, AE3, while negative for CK56, P40, synaptophysin, and chromogranin. CD3 highlights the T lymphoid cells, and CD20 highlights the B lymphoid cells. So the patient, this anterior mediastinal mass was found to be type AB thymoma. And the final diagnosis of this patient was thymic carcinoma with invasion of pericardial space with bilateral lung metastasis.
Oh, wow.
Wow. Yeah, wow. I'm lost for words. What an incredible journey you took us on, Anmol, and what a really unfortunate diagnosis. Yeah, Patricia, what are you thinking?
Wow. Okay, let me try first to gather
Yes.
our thoughts from the beginning. So, a 68-year-old male came with shortness of breath and dizziness for 1 day. On physical exam, we found that he have like tachycardia and GVT. Labs were relevant for a high blood cell count, high inflammatory marker, and yes, the EKG was showed that he had pericardial effusion. And it's from that pericardial effusion we analyzed the liquid, and that show the pericardial tap show like hemorrhagic fluid that led us to maybe malignancy or TB. And we did a CT that shows he had like lesion in the lungs too. And at the end, it's thymic carcinoma. I need to say I'm a little bit like from the beginning. I understood like everything pretty well, like from the first aliquot till the summarizing about maybe either cancer, like
Yeah.
malignancy, like yes, we talked about malignancy or TB. And you were saying that the most probable TB was something like lymphoma, but now thymic carcinoma, I'm a little lost.
Yeah.
I'm a little
Yeah.
lost.
I think I love how thoughtful you are about the entire journey and how honest you are about predicting pathology results. So every step of the way, the prediction is very logical. Heart failure with low BNP pericardium, pericardium plus systemic infection cancer. Once you start to try to predict what the biopsy shows, it's very important to be anchored in base rate. So the two most common causes of an anterior mediastinal mass are a thymoma, not a thymic carcinoma, and a lymphoma. And so to suspect thymic carcinoma before the biopsy results would be probably taking a risk because most people don't have thymic carcinoma. But you can go back and say, were there any clues that this patient had thymic carcinoma? And I would say that it's true that when a neoplasm behaves in this invasive, aggressive way, a thymoma is much less likely, and a lymphoma becomes much more likely. But lymphomas, like most liquid tumors, do not cause a leukocytosis and a thrombocytosis. A leukocytosis and a thrombocytosis is much more commonly described in solid cancers like thymic carcinoma. So the only liquid tumor that does this that I know of reliably, consistently, is Hodgkin's lymphoma, which is a small part of many lymphomas. So I think the neutrophilia and thrombocytosis is a clue that you're going to find an aggressive solid cancer like thymic carcinoma. But I think that to assume that you will find that before the biopsy results would be a leap too far to make, at least as far as my current knowledge goes. Maybe I'll learn something from Anmol or from reflecting this case. So ultimately, I think the part that you got lost in is the part that I think everybody would be lost in. I don't think there's any knowledge that I can teach you that will help you see it with more clarity, but to recognize that rare things are rare. And so you cannot necessarily predict them at every single step. And what you did so well today was to predict heart, predict infection, predict pericardial process, and then to realize that the pericardial process was part of a bigger story. I'm really curious, Anmol, what was this case like for you? What did you learn from?
Yes, and I definitely want to applaud Patricia for the amazing discussion. I think I saw this case in my night duty, and that when I saw this case, then I realized that the patient was continuing to have the recurrence of pericardial effusion. So ultimately, the plan was to create a pericardial window which prevents the reaccumulation of fluid, and therefore it offers the definitive treatment rather than we do therapeutic pericardiocentesis and patient always comes with cardiac tamponade, which can be life-threatening. So pericardial window was created and the patient was hemodynamically stable, after which he was discharged with follow-up with an oncologist as well. But then everybody was interested that if he was a known case of type AB thymoma, what was is there any past history for that? So many records were seen. So the patient had a roadside accident 2 years back, and even then in his records it was written that they are seeing an anterior mediastinal mass, which I'm not sure it was evaluated or not, but that was from an outside hospital. So I'm not sure if what was the whole duration of the thymoma, that when did it presented with lung metastasis and pericardial involvement. And then I read about the staging of thymoma. Then we staged by two methods. One is Masako system and the next is WHO system. The Masako system, it's divided into grade 1, 2A, 2B, 3, 4A, and 4B. So the 4A grading, it just tells pleural or pericardial dissemination. And the WHO system, it categorizes thymoma into 6 categories based on appearance of epithelial cells. And it divides it into type A, type AB, type B1, B2, B3, and type C. So the type A, B, and B1, they are more well differentiated. Type B2 and B3, they are moderately differentiated. And type C, it's poorly differentiated. And type AB thymoma is actually considered to be benign. It does not spread, or it could be locally invasive. But there are rare cases seen in which it can metastasize locally, maybe to the lungs or it can involve the pericardium. And that's what I actually learned from this case, that this patient, the pathologist and all, they diagnosed the patient to be having type AB thymoma, and the rest was just the spread of that disease. But the patient is stable and the pericardial window was created. So till now, we have a good results for that. Thank you.
Well, the way discussed the journey to the diagnosis was, like you planned where to put the EKG, you planned where to put the chest X-ray, you planned to where to put the pericardial fluid. It's like a master trying to tell a story. And I'm happy to be a tool to tell that story based on your creativity. And it was an honor to discuss with you, Patricia. I think for this to be your first discussion is quite surprising to me. You were cool, calm, collected, very articulate. And you even read an EKG correctly publicly, which is no small feat. So big congratulations to you as well. And now we get to hear from Lyra to summarize the learning points. Take it away, my friend.
Thank you so much, Anmol, for this amazing case. And Patricia, I was just listening. I think I can add to this. So we started the case with trying to understand the disease. For that, we need to ask three main questions. What is the time course? What is the disease? And where does it live? So for time course, we were thinking about acute and chronic presentation. Was this new acute problem or exacerbation of some chronic disease? And for finding the location of the disease, we try to look for presenting symptoms for shortness of breath and dizziness, and we combine the schema for both of these diseases to find the common ground and understand that the problem likely lies in the heart or the vascular system and the blood inside the vessels. Then when the case progressed, we faced with the question, is this infection or not infection? Because acute inflammation likely represents infection. And we asked ourselves about localizing symptoms. In this case, it was the chest. And there's a great rule that the more you're exposed to the world, the likely will get infected. And for this reason, the lungs are the most common cause of intrathoracic infection. But the disproportionate neutrophilic leukocytosis made us think about less common causes of thoracic inflammation, like empyema or pericardial disease, as was in this case. And then, very interesting pearl about heart failure with normal BNP. There are two main reasons: whether the BMI of the patient is high because BNP in the adipose tissue is cleared faster, or the second option is compression of the atria because BNP is secreted in response to the atrial stretch, and if they're compressed, there is no reason for BNP to be secreted. And for that, we were watching out for pericardial disease. And these were further reinforced by the presence of low voltages on ECG. And then a few cardiac tamponade pearls. So for diagnosis, Dr. Ravi shared a great pearl that right atrial collapse that persists for more than 1/3 of the cardiac cycle is highly sensitive and specific for cardiac tamponade. For treatment, we need fluids in order to open up the collapsed atrium, even with the presence of GVD, which may seem confusing at first. And for etiology, the most common cause of pericardial effusion is actually idiopathic pericardial effusion, but we need to watch out for other causes like cancer, infection, or injury-related pericardial disease if we have two signs. First is cardiac tamponade, and second is signs of systemic inflammation. And then differential diagnosis for anterior mediastinal mass, a great pearl that we need to consider not only the infamous 4Ts, but also fibrosing mediastinitis from tuberculosis.
Oh my gosh. Well, I don't even know what to say anymore, but I would just keep it very simple. The world of clinical reasoning is unfortunately very, very biased with historical dominance by men. And yet today we have Sausan scribing, Patricia discussing, Anmol presenting, and Lyra doing an outstanding teaching points. Thank you to all four of you. You are outstanding, and pretty soon I think the landscape of clinical reasoning will be dominated by outstanding women like you. So I look forward to becoming obsolete, and we'll cherish that, and the time is coming soon. All right, y'all have a wonderful rest of your day. Thank you to all four of you. Bye.